And ESS's mission is to create a world where individuals with Down syndrome thrive. We do this by driving policy change, providing resources, engaging with local communities, and shifting public perceptions. Our work is achieved through four key pillars: resources and support, research, advocacy and policy, and community engagement. Like I said, I am on the health and wellness team, and some of what the health and wellness team does is health policy and advocacy. We develop resources such as our guidebooks, web pages, one-pagers, and we also have a health and wellness newsletter. So if you'd like to stay informed about our new resources and webinars like this one, I highly encourage you to sign up for that newsletter, and you can find the link in the chat. Some of the resources I want to highlight today are 321 Go, which encourages healthy choices in physical activity, balanced nutrition, and emotional wellness among adults with Down syndrome. And we also have a practicing inclusive mental health care guide as well. I'm very excited about our speaker today, Dr. Ruth Brown. Dr. Brown is a licensed clinical psychologist and assistant professor at Virginia Commonwealth University. She has worked closely with families and self-advocates with Down syndrome for over 10 years to better understand mental health needs and improve care for people with intellectual and developmental disabilities. Dr. Brown's research focuses on helping individuals with Down syndrome who are dealing with stress, anxiety, depression, or trauma. She created Thriving, a free online training that teaches caregivers and professionals how to recognize signs of trauma and support healing in adults with intellectual and developmental disabilities. Her goal is to make mental health care more compassionate, accessible, and responsible to the real-life experiences of individuals with Down syndrome and those who love them. Dr. Brown, I am going to stop sharing my screen and turn it over to you.
Great. Thank you so much, Blake. And thank you to the DSS team for having me be able to present and talk about this topic. And also, for those who are attending, I am presenting from the Newark airport. So hopefully this will go smoothly and we won't have any interruptions, but I had a flight cancellation and delay. And so hopefully this will work smoothly. So a little bit more about me. So like had a great introduction. I also run the Hope Lab at Virginia Commonwealth University, and HOPE stands for Healthy Outcomes Through Psychosocial Equity. Basically, that idea is that we do research to try to improve access to mental health care for people with intellectual and developmental disabilities. And we have a really amazing team of undergraduate and graduate students and self-advocates that work for us, and they are super dedicated, and it's a joy to work with them every day. All right, let's see. Can you see the screen okay?
Yes, we can see your screen.
Okay, great. All right, get my control started here. Okay, so the things that we're going to be covering today, first we're going to talk about just understanding what stress and trauma is, the difference between stress and trauma, how they're similar and different. Then we'll talk about understanding the effects of stress and trauma on adults with Down syndrome, including kind of how that may impact their health and well-being, and how it may uniquely impact them compared to maybe people who are neurotypical. Then we'll be talking about ways that caregivers can support adults with Down syndrome who've experienced chronic stress or trauma. And then finally, we will talk about self-care. That is really, really important for caregivers and oftentimes overlooked. So we'll spend some time talking about that as well. Before we kind of dive into the content, I also just want to say that just kind of foreshadow a little bit of the self-care to talk about just the need that this can be a kind of a heavy topic. We're not going into anything kind of particularly, graphic or any details or anything, but it still can be hard to talk about. And so if you need to, feel free to, take a moment and come back to the content if needed. Talk to someone you trust or do something relaxing, maybe after this webinar if it's distressing for you. Okay, so first, understanding stress and trauma. So first we'll talk about stress, like what does stress mean? And when I'm using the word stress, how I'm using that word, because it can mean a lot of different things. So generally we think of stress as being a feeling of pressure, worry, or tension caused by a difficult or challenging situation. Generally stress is a kind of there's kind of short-term manageable stress. And this can actually be a positive thing that can help us grow and develop. we kind of have opportunities to develop resilience and grow kind of greater stress tolerance over time when we experience kind of short-term, manageable stress. However, chronic unmanageable stress can cause wear and tear on our bodies and minds. So when that stress is kind of going on and our bodies are in this state of kind of fight or flight over time, then that can lead to kind of long-term mental and physical health problems. So then what is trauma? So trauma is a word that gets thrown around a lot. It's all over social media, for better or worse. But it also has kind of specific meanings, and the way that I'll be using it in this talk. So a traumatic event is an event that is perceived as frightening, dangerous, or violent that poses a threat to a person's life or bodily integrity. It can involve witnessing a traumatic event to another person, especially a loved one. So a person doesn't necessarily have to be the person experiencing it or the victim of a traumatic event. But if they witness or learn about it happening to somebody close to them, that can be traumatic as well. And then the greater the perception of threat, either to life or to body, the greater the kind of traumatic stress that the person experiences. And I've highlighted a few of these things, these kind of key points, mostly about perception, that it's really about a person's perception. So whether or not the person was actually in threat, it's whether or not they perceived it. And that's, I think, really important when we were talking about people with intellectual disabilities or people with Down syndrome, is that their kind of perception of these events may be different than their caregivers or their family may kind of consider. And so if we think about it, as a continuum of stress on one side and kind of trauma on the other side, where a person, how a person kind of experiences an event can fall anywhere along this continuum. For one person, they might experience it as just being upsetting and stressful. And another person, they might experience it as traumatic. And the first time that I really, as a clinician, kind of got kind of like, I guess, awareness of this concept was when I was doing diagnostic interviews with combat veterans for a research study. And so I was doing just day after day interviews with combat veterans about their experiences overseas in combat and whether or not they developed post-traumatic stress disorder. And hearing the veterans talking about their experiences, it was really eye-opening to hear how some people could experience the same or very similar events. And for one person, it was traumatic and they were terrified, they had a hard time kind of coping with it in the moment. Maybe they experienced symptoms afterwards. And then for others, simply, have bullets whizzing past their head. They can hear the sound of it and they're just like, it was exciting. Or, it's like, so it really, really varies from person to person. And so that's important to keep in mind that, that people really are there's a lot of individual difference there. Okay, so let's then talk about understanding the impact of stress and trauma on adults with Down syndrome. So now that we have a kind of a shared terminology. So people with intellectual and developmental disabilities are more likely to experience things like social exclusion, institutionalization, bullying, abuse, sexual abuse, and loneliness. So there are quite a few studies out there about people with disabilities and people with intellectual and developmental disabilities. There are very few studies that are specifically about people with Down syndrome that explore kind of stress and trauma. And that led me to conduct a study several years ago to try to get a sense of that, like what are the kinds of stressors that people with Down syndrome experience. I was able to get funds from the National Institutes of Health for a Career Development Award to look at this question, and I created the LEAF study, the Life Experiences and Feelings Study, to understand the impact of stress and trauma on people with Down syndrome. So we interviewed 127 kind of children and self-advocates with Down syndrome and their parents. They had either Down syndrome or mosaic Down syndrome. They were recruited through kind of national registries and Down syndrome advocacy organizations, and they were between the ages of 12 and 45. And for this part, the data that I'm showing here, we asked about stressful experiences that they'd experienced in the past 2 years. So if we're looking here, what we have at the top are events that we consider to be kind of potentially traumatic. And so those are those, kind of more serious ones that maybe involve, the loss of the life threat or bodily integrity to themselves or someone else. And so we see pretty high rates of experiencing the death of a relative or a close friend, serious illness or injury to themselves or to someone else, as well as pretty high rates of bullying or abuse. One thing to note is that this took place, like the study was going on when the pandemic hit. And so quite a few of these are kind of COVID related or pandemic related. Similarly, here are things that we classify as being kind of other stressful life events. So maybe they're not technically classified as like a big T trauma, but they are still stressful. We see, again, pretty high rates, 60% experience some sort of significant school or work change. And again, with that being during the pandemic, that's not surprising. But kind of other lots of other stressful things. So we see, quite a few stressful experiences that people with Down syndrome are experiencing. Unfortunately, there are also a lot of myths that exist about people with intellectual and developmental disabilities, including people with Down syndrome, in terms of how trauma affects them. So here are some examples, of common myths that caregivers or professionals may have about trauma. And so a big one is that professionals may think that people with intellectual and developmental disabilities can't engage in treatment, like cognitive behavioral therapy or trauma-focused interventions. They may think that standard mental health treatments are ineffective for them, that they can only use behavior modification, that people with intellectual disabilities don't experience trauma. There are a lot of people who believe that people with intellectual disabilities are somehow protected from trauma because they don't have the kind of cognitive abilities to, to kind of process or experience it. There's a common myth that working with people with intellectual disabilities requires significant specialized training. And so they feel like if they don't have that training, then they can't provide those services. There's a problem of diagnostic overshadowing, which is a term that we use to describe when things like challenging behaviors get or explained by the intellectual disability rather than thinking kind of with a broader picture, thinking that maybe the challenging behavior could be because of some other underlying medical or mental health issue or trauma. And people think that people with intellectual disabilities are protected from trauma because of their mental age, or that they don't remember what's happened to them, they're not aware of what's happened to them, or that their kind of IQ scores tell you everything that you need to know about the person. So unfortunately, these are kind of common myths, and we want to kind of expel some of those myths. So what we do know from research is that people with intellectual disabilities do experience impacts of stress and trauma. We're going to talk about a few kind of categories of these impacts. So it can affect brain development, it can affect behaviors, emotions, relationships, and physical health. So we'll talk about each of these one by one. Okay, so trauma and chronic stress can affect the brain. And so these are some examples of where the most research has been done on the effects of trauma on the brain. And so it can cause kind of biologically driven changes in thinking, feeling, and behavior. So these are a few areas of the brain. You don't have to memorize these. The main thing to think about though is that these kind of areas of the brain, the amygdala, the hippocampus, and the prefrontal cortex are the parts of the brain that are affected by stress and trauma. So the amygdala is that kind of threat sensing part of our brain. Like the main kind of function of the brain is to detect threat. And so that gets activated by stress and trauma. And so people who've experienced it, they kind of have this like heightened sense of threat. So even when they're safe, kind of after the event, years later, they may still have this kind of heightened sense of threat. The hippocampus is involved with learning and memory, kind of being able to learn. I was, in a dangerous situation there, but now I'm safe, or these are the places I should go, those are the places I should go. Like all of those sorts of things that are involved, can be impacted. And then the prefrontal cortex, those are our executive functions that help, those are the parts of our brain that develop later, in adolescence and adulthood. And that's involved with attention, planning, and emotion regulation. And so not only are these areas of the brain kind of impacted, but the communication between these parts of the brain are impacted as well. And so then that makes it harder for the person to be able to, like when that, that kind of, oops, the amygdala gets activated, normally, what would happen, or kind of under ideal circumstances, what happens is that that threat part of the brain gets activated, but the executive function part of the brain kind of kicks in and says, okay, wait a minute, everything's okay, calm down, take some deep breaths or whatever, it kind of helps to kind of re-regulate that the kind of communication between those are impacted, and sometimes is weakened, and that leads to this kind of repetitive, kind of ongoing activation. So the point here is really that the sorts of things that can then lead to what we might describe as challenging behaviors in a person with intellectual disabilities, is coming from a biological process that's been kicked off by experiencing stress and trauma. And so that helps us, I think, to have a little bit more, maybe sympathy for the person, but also have a better sense of what sorts of things they need in order to kind of help them recover. Okay, so trauma can impact behaviors as well. So some things that we might see um, as a result of trauma. A big one is avoidance. We can see the kind of emergence of avoidant behaviors, and that can be actively avoiding people, places, or activities that are reminders of the trauma. There's also kind of mental avoidance too, that people will try to do things to distract themselves from the thoughts or memories of the event too. And so that's a little bit harder for caregivers, I think, to observe. But that can be, that kind of mental avoidance is also common. You might see changes in routine, including sudden changes in kind of eating or sleeping patterns, kind of new or worsening nightmares. And the nightmares don't necessarily have to involve the traumatic event. So if a person was in a car accident, they might not necessarily be having nightmares about car accidents. They could be having nightmares about something else, kind of similar, or there could be some element of the experience that kind of emerges in the nightmares. Or they may just be, kind of nondescript nightmares, but they may start having an increase in nightmares afterwards. They may have greater difficulty falling asleep, and that may be part of that avoidance, that maybe they're avoiding sleeping, or they're feeling a lot of fear and anxiety at night because they're having nightmares. And so those are some things to think about. Kind of regression is another one, and here I'm using regression, in the more general sense, not necessarily the specific kind of Down syndrome regression disorder, but more just a kind of a loss of learned skills, and it's possible that could, then turn into the the kind of big R regression, but you may also see just other loss of skills, with toileting, communication, or activities of daily living may decrease. We can sometimes see an increase in self-stimulatory behaviors, so rocking, pacing, or other repetitive movements, and that may be a way that they have of kind of managing the physiological arousal, like that threat center is getting activated, and it's a way of kind of coping and handling some of the kind of energy from from those experiences. And then we may see an increase in externalizing behaviors. So an increase in aggression, agitation, self-injurious behaviors. These can all be signs of internal distress that the person is experiencing, if they don't have the ability to be able to communicate that. especially in the moment when they're feeling activated by something. And so we see an increase in externalizing behaviors. Trauma and stress can also impact thoughts and emotions. And so that can look like, and these could maybe a little bit harder for caregivers to observe, but some of the things that we can see might be kind of increased, sadness or emotional outbursts, increase in like irritability, being crankier, grouchier, yelling, snapping at people, reactions that seem to be out of proportion to the current situation. So they may just be overall more emotional. Hypervigilance, that's that kind of being in a state of, constant on guard, being alert, kind of always looking around, looking behind their back, not wanting to, not wanting to be alone, or, not wanting others to be around them, not wanting other people to touch them, maybe being easily startled. People can start having kind of more or increased negative thoughts about themselves, about the world, about others. They can have difficulty trusting other people, or they may feel worthless if something's happened and they feel like they're damaged, or they've been hurt, that they can't trust anyone. We can see kind of increased difficulty concentrating, and that can look like having, difficulties emerge at work, at home, at school, at a day program, if they're kind of losing their ability to focus on a task that they used to be able to do. And they may experience some confusion or disorientation, especially if they're reminded of the stressful or traumatic event. That can look like, for some people, it can look like even psychotic-like symptoms, if they're having kind of flashbacks or dissociative events where sometimes people feel a sense of being outside of their body, when they get kind of triggered, when something triggers a memory of the event. And that can be hard for a person with an intellectual disability or with limited verbal abilities to be able to communicate that feeling. And so then sometimes that can look like, that kind of disoriented kind of, psychotic-like experiences. Trauma and stress can also impact relationships. So I mentioned before, they may have difficulty trusting other people if they've experienced abuse, for example. They may need more reassurance than before. They may be kind of constantly asking for reassurance from caregivers, and they just may need more kind of day-to-day support or more kind of behavior management. And than before, if they're starting to have some more kind of aggressive sorts of behaviors and things like that. That emotional dysregulation, the kind of irritability, moodiness, intense emotional outbursts, can take its toll on friends, families, and caregivers. And that can impact relationships as well. They may kind of lose friends or, or support. And then caregivers and family may have also experienced trauma, and that can make it extra hard, for the caregiving system for that person too. And it could be that the caregivers experienced the same event, the same kind of stressful or traumatic event. So maybe they were in a car crash together, or they experienced a house fire or a natural disaster. And so that was something that impacted the person with Down syndrome, but also impacted their caregivers. And that can, that can make it a more challenging situation. Caregivers can also experience what we call secondary traumatic stress, and that's when they experience traumatic stress symptoms in response to learning about their loved one experiencing trauma. So they hear about their loved one, being abused, for example, and then they themselves develop traumatic stress symptoms from that as well. And then caregivers can also have just their own trauma histories, that may be completely unrelated to the event that the person experienced, but that kind of triggers that experience in themselves too. And then that can impact the relationship as well, because it impacts the caregiver's own well-being and what we call their kind of like window of tolerance, kind of how much they're able to, kind of manage or tolerate the distress from the person with Down syndrome that they care for. And then finally, trauma and chronic stress can impact physical health as well. So there's a wide body of research in the general, within the general population of the effects of chronic stress and trauma on health. And that includes cardiovascular disease, chronic pain and headaches, inflammatory diseases, metabolic disorders, and immune disorders. And what we're learning more and more is that people with Down syndrome already are at high risk for a lot of these physical health conditions, just as as a result of having an extra 21st chromosome. And so that some of those things kind of lead to increased risks for autoimmune conditions, for example, or metabolic disorders. And then when we add stress and trauma on top of that, that can, there's a potential, and we haven't thoroughly studied this in people with Down syndrome, and this is an area of research that we really need, is to understand how does, kind of layering stress and trauma on top of that kind of pre-existing vulnerability impact their health. But I would say we can at least say that it impacts them, just not to what degree. And so one thing to think about, another point that I like to make, because even as a stress and trauma researcher, I tend to see a lot of things through a stress and trauma lens. And when have a patient, for example, who is coming into the clinic and they're having a change in behaviors and emotion and kind of coping related issues. One of the questions I'm asking is this potentially trauma related? Has something happened to the person? And I think it's an important question to ask, and I think one that we need more providers to be asking. But I think it's also important to just acknowledge that it's not always trauma, that sometimes there are other kind of underlying issues that are going on that are not necessarily trauma. And so that could be because of other kind of neurodevelopmental issues. Maybe they have ADHD, maybe they have autism, especially if we're talking about kind of young kiddos. And we're seeing these things. If these symptoms are emerging in adulthood, then it's less likely to be because of a neurodevelopmental, kind of co-occurring neurodevelopmental issue. We would have seen that in childhood. And so it could be that there are other underlying medical issues. And so we need to make sure that the person has had recent checkups from their primary care and maybe considered other sorts of things that may be going on. Sleep apnea, for example, is a big one. So we're seeing big changes in sleep. It could be because of nightmares and trauma, but it could also be because they have uncontrolled sleep apnea, and that's putting them in a place where they're not getting deep restorative sleep. They're more likely to be in light sleep, where they're having dreams and nightmares. And so we need to make sure that that's being addressed. They may have GI distress, that they're having a hard time communicating. They may be having dental pain. These are some of the big ones that we can see that could lead to a sudden change in behaviors. And it could also be just general emotion dysregulation. They may just not have the tools in their toolbox to cope with, with life changes or situations that are coming up. Difficulty with communication can lead to some of these behavior changes. There could be some other kind of behavioral function that the behavior's serving, or it could be a combination of these. So it could be trauma and some of these other issues. And so we have to be mindful of that too, that we're not just thinking we find one explanation that explains it all. Okay, so let's talk now about kind of how do we support the person. So maybe we have reason to believe that, stress and trauma is at the heart of what the person is experiencing. And so what can we do to support them? I kind of think about four, different types of reactions that caregivers might have in response to kind of traumatic stress symptoms. The first two, we tend to see when people just don't fully understand like trauma and the impacts that trauma have. And so the caregivers may just kind of ignore or to kind of minimize the effects of trauma, or they may become like reactive to the behavioral manifestations of the trauma. And so they kind of end up in a reactive state where they're reacting to the person. The person with Down syndrome is becoming more emotionally dysregulated. They're having angry outbursts. They're more irritable, and the caregivers are just reacting to that, like, the challenging behaviors. Or they're downplaying the trauma. Oh, it's not that big of a deal. It was just a little thing. It happened so many years ago. Like, why are they still upset about this? And so it's kind of an ignoring and minimizing it. And so we definitely don't want to be in this sphere, but that's usually when people just don't understand. Once people kind of understand trauma and kind of become more like trauma informed is a term that people use a lot, then they may kind of fall into this, kind of excuse or respond phase. And so the excuse piece of it is, well, they understand, okay, well, this person experienced trauma. It was really hard for them. And so but then they kind of let them get away with things that maybe they shouldn't be doing, or they try to accommodate them and try to protect them further, which I think is often coming from a noble place. But sometimes what happens is that it doesn't give the person the tools that they need to move beyond the trauma. And so in some ways they end up getting kind of, I think, stuck, kind of more entrenched in the traumatic stress. And so they may just kind of let things slide. They avoid, kind of discipline or behavior corrections or behavior modifications, because they feel like that they're kind of helping them in some way, or they're not being kind of held responsible for their actions, um, or they don't want to push them. And so instead, what we want to be is trauma responsive. We want to kind of respond to the trauma. And so we do that by kind of acknowledging and recognizing the impacts of trauma, recognizing that the things that they're doing maybe are not their fault, but then also working with them to help them kind of move past it in a compassionate but kind of effective way. And so that may be, using terms like, I understand how you feel. Of course you feel that way. You feel upset, or you're scared. Of course you feel that way. Like, let's work on this together. Like, how can I help you, kind of move forward? And so emotion coaching is, I think, a helpful framework. This is an approach that was developed by John and Julie Gottman of the Gottman Institute. They've studied, kind of parent-child relationships, marital relationships, and kind of what leads to healthy relationships. And they developed this idea of emotion coaching, this framework. And I think it's really helpful. And I think it fits really well within a trauma-informed framework. And the basic idea of emotion coaching is that you recognize and accept emotions. And so the general idea there is that all emotions are okay, even sad emotions, angry emotions. That's all part of being human. And for our loved ones with Down syndrome, like, they're human and that they're allowed to have emotions. They're allowed to feel scared. They're allowed to feel angry. They're allowed to feel depressed. They're allowed to feel happy and excited. Like, we recognize that they have the full range of emotions that everybody else has, and that it's okay for them to have those emotions. And that helps them to also feel more comfortable with having those emotions themselves. That we don't want them to feel like they have to project happiness all the time. That I think sometimes they're expected to be happy. There's that kind of idea that they're always happy. And I think that puts a lot of pressure on them sometimes to be happy, to fulfill that role. And we want to make sure that they feel like they don't have to be happy all the time. It's okay to not be happy. And so then, after recognizing and accepting emotions, we use emotions as a way of connecting with the person, that they need to feel connected, to their caregivers, to their friends, their family. And so emotions and talking about emotions can be a way of connecting. And we do that by helping them to, understand, like, not only is it okay, but I feel that way too. Like, there have been times where I've been scared. There are the times when I've been angry. And that helps to connect them. And then they're going to be in a place where they're going to be more accepting and willing to move forward together. If they feel like the emotion is okay, they're not alone in that feeling, it's going to be easier to kind of move forward from that. And so then the final piece of emotion coaching is setting clear and consistent limits on a behavior and saying some things are not acceptable. Like it's okay to feel angry. It's not okay to throw things, or, and problem solving then is then coming up with a plan of how to address that in the future. And so like, let's find a better way of handling that emotion. Like, what's a better way when you're feeling angry of expressing anger? What's something else that you can do in helping them then to learn those new skills? And that's that piece of, that's where we move from excusing, behaviors because it's, part of the trauma to helping them be responsive and moving forward is by setting those limits and problem solving. And we're doing it from a much more compassionate framework. Okay, so some suggestions then for how we can, kind of use emotion coaching with adults with Down syndrome, who may have, kind of lower verbal skills, for example. We want to use simple and clear language. So we want to avoid jargon or complex explanations, especially if they are in a state of distress. If a person is upset, they're scared, they're angry, they're in fight or flight, like that's not the time to engage in emotion coaching in the moment. They're not going to be able to process what we're saying. We may have to just wait out the storm and wait until they're calmer and then engage them in a conversation talking about what happened afterwards. So you keep things simple, short phrases, validate their feelings. And so you can say things like, I see that you're scared. That must have been very frightening. So again, we're showing that we understand and accept the emotions. We're not judging them. Sometimes we have to be a feelings detective. If they don't have the words or the ability to be able to communicate their emotions, we have to do it as caregivers. We have to really try to think, be empathic and think about how would we feel maybe in that situation, pay attention to other verbal cues, their facial expressions, the other things that they're doing, looking for patterns. When are they, doing certain things, reacting in a certain way? So then you can see if they look like they're agitated, for example, you can say like, you look upset. Can you show me what's wrong? Or kind of engaging with them in that way. Offer choices and not demands. So one of the big things about stress and trauma, especially kind of chronic stress and trauma, is that people often feel like a loss of control, a loss of autonomy in their lives, and that can increase the stress. And so by offering choices, we help to give them back some of that autonomy and control, which can help them. And so instead of saying, you need to calm down, you might say, offer them choices. Would you like to listen to music or sit in a quiet corner for a few minutes? That again gives them that sense of control. And then practice active listening, being patient, giving them plenty of time to communicate their thoughts and feelings in whatever way that they can. Co-regulation is another important, kind of method of being trauma responsive. This is the idea that in order to help them regulate their emotions, if they're in a state, highly emotional, dysregulated state, we can't calm them down by matching them in their level of distress. We have to be calm and help provide that sense of stability to help them come back down. And so you can model calmness. You may have to take deep breaths yourself. You may have to take a moment, lower your voice, slow your breathing, relax your body, kind of do all the things basically that you would want them to do. You may need to kind of create a safe space for them. If there's an opportunity to kind of reduce sensory input, kind of go to a quieter place, less crowded area if you're in public. Have some sensory tools available, weighted blankets, stress balls, soft music, figure out what that person likes, and try to have some tools that are available for them. whenever they have, or whenever they may need those tools. And then practice some grounding techniques together. Practice these as much as you can. Practice them during times when they are calm and they're in a good mood. The more that you practice them when they're already calm, the easier it's going to be for them to be able to use those tools when they need them. If you're only trying to get them to, to use, grounding techniques when they are in that, kind of emotional state, they're not going to be able to use them. So you have to really practice and make it fun, make it a positive thing that you do together, and help them to do that, develop that as a skill so that they can use it when they need it. And then, work on building coping skills that, this is I think, something that we're not teaching enough in schools. And I think especially in special education classrooms are oftentimes not, using social emotional learning curriculums that are adapted for people with intellectual disabilities. And so oftentimes they don't get enough emotion education. And so you can help fill in some of those gaps by helping them to build some emotion vocabulary. So I think some of these we kind of mentioned, like the idea of kind of calm down kids, celebrating small successes, try to like catch them being good is a term that we use a lot with children, but I think this is helpful for anybody, any relationship is helpful to, to try to make sure that we're drawing attention to the things that we're appreciating the other person is doing. And so that we're doing that too. We're catching them when they are using coping skills and, praising and reinforcing that. There are lots of kind of great strategies that are out there for developing emotion education. It can be harder to find some that are suitable for adults. A lot of them are developed, for younger children. But there are some, for example, things like, emotion pictures that have adults on them. You can find adult coloring books and things like that that can be still appropriate for adults too. But playing games, talking about emotions can be really helpful. Visual supports can be really helpful, even for somebody who has verbal skills. Having some visual supports are really helpful because sometimes when we're really emotionally activated, we just don't have kind of access to that part of our brain. And so having some visual skills can, or visual supports about emotions can be really helpful for both helping them to communicate their emotions, but then also helping to cue them for some maybe coping strategies that they can use that they like to help them access those in the moment. Using social stories and role plays can be really, really helpful. There are lots of resources now online. So if you search for, social story and then whatever, the topic is, there are lots of ones available online that you can print or adapt. Some things to think about for an effective social story is, kind of it teaches about maybe an expected behavior or an expected skill or a helpful skill. It offers kind of clear and positive actions. So the idea of the social stories, it kind of teaches what we want them to do or what is the kind of helpful skill. It focuses on what to do and not what not to do. So for example, it might say, I can ask, if I feel upset, I can ask for a break, rather than saying, I don't run away when I'm upset. That's focusing on the thing that they're not supposed to do. Instead, we want to focus on the things that they are supposed to do or that would be helpful for them. There are lots of like more and more kind of books on kind of trauma and coping. Some of these are written for kids, but may, depending on the person's preferences, might still enjoy, some of these books, but also just may give caregivers some examples of kind of some ways of talking about, trauma or scary kinds of things. So it may be worth kind of looking at some of these books, even if you're not planning on like reading the books to them. Excuse me. But these books are nice because they're non-confrontational. They help to normalize the feelings of being scared, or impacted by trauma. oftentimes they model, the character, kind of overcoming or being resilient, which is really helpful. And it can maybe be a starter for having conversation. Maybe if they don't want to talk about what happened to them, they may be more willing to talk about what happened to a character in a book. And then that may start to kind of create that opening. And then caregivers can also help by helping the person to make meaning. There's a long tradition kind of in psychology and psychiatry about making meaning of traumatic events. And it can be really helpful. And a lot of the kind of trauma focused kind of cognitive behavioral therapies, for example, use kind of narrative approaches as a way of kind of helping the person to make sense of what happened. And this can be helpful. We can use some of those storybooks or, social stories and things as tools for that. But the idea is to kind of help, kind of create a beginning, middle, and end of what happened and kind of put the pieces together. It's really important that, that kind of creating these stories or timelines, they can be drawn, they can be written, they can be acted out, they can be done in many different formats. But they should always, always, always end with the present moment and emphasizing that they're safe, or that they're strong, that they're brave, and so that then that helps to kind of get them out of that mindset of, of being a victim or, or whatever, helping them to see that how far they've come, for example. So that's another really helpful tool. All right, so when to seek professional help. So if the person is really struggling and it's having a negative impact on their life, on the family, on others, if it's been going on for, for weeks, months, then it's a good time to seek professional help. If they're starting to engage in behaviors that are a safety risk to themselves or others, or as a caregiver, you're feeling kind of overwhelmed and not sure how to help them, then reach out for support. So finding a therapist, ideally in an ideal world, there would be therapists who specialize in working with adults with intellectual disabilities. Unfortunately, that's not often the case, but it's a good place to start. Is kind of asking your primary care doctor or their primary care doctor for a referral. Check your local Down Syndrome Association, your kind of state or local ARC or Special Olympics programs may have some connections with therapists in the community. Every state has a University Center for Excellence in Developmental Disabilities, and they often have kind of professionals from multiple disciplines, and they may be able to have some suggestions of psychologists in the areas. Other support groups such as Parent to Parent USA can help. But unfortunately, specialists are really hard to find. You may not be able to find, so don't recommend calling therapists necessarily unless you've gotten a referral from one of these other groups that this is a person who specializes in intellectual disabilities. If you're just reaching out and calling therapists, chances are they won't have experience. If you ask them, do you specialize in adults with intellectual disabilities? They, or with Down syndrome, they probably will say no. And so that, you may be able to find a therapist who's willing to help, but they may not feel like that's their area of expertise. And that was part of why NDSS created this practicing inclusive mental health care to individuals with Down syndrome. This is one of the things that myself and a colleague helped to create. And so the idea there is that that can be a tool that then parents can, recommend to a therapist who's, kind of willing to try and willing to, to learn new things to give them some skills that would be helpful for them. All right. And last but not least, self-care. So the big thing is putting on your own oxygen mask first. And so if you've flown on a plane, you have probably seen an image similar to this on the safety card or the safety demonstration. But they say to always, if you need an air mask, put it on yourself before helping others. Because if you try to help the other person like you're losing air pressure, you try to help the other person and you pass out, you're not going to be able to help them anymore. So you have to put your own oxygen mask on first so that you make sure that you can be there to help the other person. So this is true, from an emotional perspective too, that you need to make sure that you're taking care of yourself. Another phrase that I really like is you cannot pour from an empty cup. So take care of yourself and don't feel guilty about taking care of yourself because that's, it's important for the other person too. Um, so some things to look out for, signs of burnout are emotional exhaustion, feeling drained, depleted, or having a short fuse, having a sense of depersonalization. That means becoming kind of cynical or detached from the person that you're caring for. You may feel a reduced sense of accomplishment, like your efforts don't matter, you're not making a difference, or increased physical symptoms like headaches, stomach aches, getting sick all the time, having difficulty sleeping. So take care of yourself, get plenty of sleep every night, eat, uh, take care of yourself, exercise, all those things kind of help with those stress hormones, and get regular health checkups. Do things to take care of your emotional well-being, practicing mindfulness can help. Even just a few minutes a day kind of helps to release the cortisol that, caregivers may be experiencing as well. Set boundaries, engage in hobbies, limiting news and social media is also really important. Try to have, or at least use, kind of positive things, look up inspirational things online rather than doom and gloom. Build up your support system, connect with other caregivers, can be really helpful to have, to know others who have gone through similar situations. Ask for help, consider respite care, and talking to a professional. All right, so I think I have just a few more slides. So one of the things at the end of this webinar, what I hope everybody does is take a few minutes to think about and write down, maybe you can do this right now, think about what is something that recharges you. Something simple, something easy that recharges you. List 3 people that you can call for support if you need help. Identify one small self-care activity that you can do this week, and then, kind of write it down and make a plan to make that happen. And then the key takeaways from this one is that trauma is a response to a perceived threat. And so whether or not maybe you don't think it was that threatening or that stressful for that person with Down syndrome, it may have been. People with Down syndrome experience trauma, and behaviors are often a form of communication about their internal distress. So be trauma responsive and not permissive. The goal is to support and teach skills while maintaining kind of structure and boundaries to help them move forward and move beyond the trauma. Focus on creating safety, predictability, and control to foster a healing environment, and take care of yourself because it's not a luxury, it's a necessity. All right, I'll start there or stop there for questions.
Thank you so much, Dr. Brown, for all this really valuable information. We have a few minutes to answer a couple questions. The first question we got was, how can a caregiver be trauma responsive if, what are some tips and techniques if their loved one is either non-speaking or non-verbal?
Yeah, so I think they're thinking about ways of communicating like safety. I think is a big thing. I mean, it can be hard, like that's where you really have to be, that kind of a detective, that feelings detective, and really thinking through like what are the ways that this person has of communicating, and what is it that I think that they're feeling, what is it that they need, and doing things to help. Again, kind of sometimes we have to just be really, really kind of basic and providing just, those choices, offering choices, kind of communicating safety, using social stories. I think it's helpful to remember that oftentimes for people with Down syndrome, their receptive language skills are better than their expressive language skills. And so they may not be able to easily communicate, kind of verbally or with a, communication device. but they may understand more, and so using our words in a really gentle way. There's an approach called gentle teaching. It's a therapeutic approach. It was developed in like maybe the Netherlands or something. But if you search for gentle teaching, and it's a strategy that really focuses on kind of helping people heal, heal from kind of trauma and stress, who oftentimes have kind of more multiple and severe disabilities. So that's an approach that I think could be really cool. There's some really great YouTube videos on gentle teaching.
Great. We had a couple questions that were related to this to different behaviors. How do you touched on this a little bit of but how do you know if this is a sign of a trauma response, or how do you know if it's an indication of something else? And what would be a good starting place you would recommend?
Yeah. So a good starting place is a medical workup, making sure that like and check all of the boxes. I would say, kind of go through for one thing, like the adult medical care guidelines, kind of making sure going through that list and kind of checking for all of those things, making sure everything's up to date, blood work. I mean, some things, some extreme kind of behavior and mental health changes come from, dietary deficiencies that, kind of can come on pretty strong, so like making sure like they've had blood work, sleep apnea, are they wearing their CPAP machine? Is there something to be done there? I mean, sometimes we know something has happened to them, that they've experienced something, and so that we know. And so do we see that change happening within the days or weeks after, after the event? Can be helpful, but sometimes we don't. Sometimes we don't. Maybe we suspect something's happened, or we just don't know. Um, and so then it's a matter of kind of looking for patterns, keep a log of, what are we seeing? What are the symptoms? How often is it happening? When is it happening? Engaging a, behavior analyst, or, to maybe do a functional behavior analysis can be helpful, and looking for also like kind of positive behavior support. So if you look for a positive behavior support provider in your area too, oftentimes they think more and more, they're getting some like trauma informed care training. But somebody I'm a big fan of positive behavior supports and thinking about the whole person and what's important to them, and incorporating those things I think is really important too. So sometimes it just takes, that document, and that's helpful for the primary care doctors too, another, and then like the medical workup to document, these are the things that I'm seeing, that this is when it started, this is how often it's happening. That can provide really useful data to a psychologist or a doctor, and kind of teasing those things apart, because sometimes it is hard.
Hmm. We're at time. Do you have time for one more question, Dr. Brown?
Sure.
Okay. We got this question a lot and kind of a lot of different ways, but how would you recommend explaining whether it's a close friend, a loved one, a family member, but the death of someone that was important to someone with Down syndrome, or even like a pet, or maybe it was their horse they ride in horse therapy? Do you have any specific strategies on that? We had quite a few questions on this concept.
What was it? You didn't quite catch the question.
Sorry, like
Sorry.
the death of a close person or animal or pet to someone with Down syndrome. Do you have any strategies to kind of explaining that concept?
Yeah, that can be a really hard one. That is, that kind of grief and loss, is is a big kind of stressful event. And it does seem like people with Down syndrome, maybe in particular, I don't know if they have a kind of a stronger like autobiographical memory, where they like really remember things very vividly even years later. And so I think that's a part of it too. But yeah, there are some good resources that are out there at the Advocate Center, Dr. Chacoin's group. They've
Yeah,
got
the advocate medical group. Yeah.
yeah, they've got some great grief resources, and using kind of visual strategies and visual guides too, for kind of talking about loss. There's some great books online, again, kind of children's books, but some of them, if you kind of look through different books, some of the imagery and stuff is not too childish, that it can still be helpful, talking about, grief and loss. Okay. And I think depending on the person's spiritual beliefs too, kind of connecting it with that can be helpful. Um, but allowing the person to talk about it, I think is really important. I think too often caregivers try to not talk about it, try to, minimize it, change the subject because they don't like seeing their loved one suffer. But they need the opportunity to be able to talk about it, to process it in order to be able to move past it.
Yeah. That's really helpful. We'll include some of these resources in the follow-up email as well. That is all we have time for today. If we did not get to your question, please email us at health@ndss.org. We'll can drop that in the chat one more time. Again, thank you so much, Dr. Brown. This is really great information, and we're really appreciative of it. So
Yeah,
thank you and
absolutely.
have a safe
My
trip back.
pleasure. Great. Thank you. Thank you.
Bye.
Bye.